Chapter 59 Delirium. The three most common cognitive problems in adults are dementia, delirium, or acute confusion, and depression. Although this chapter focuses on dementia and delirium, depression is often associated with these conditions. Depression is often mistaken for dementia in older adults, and conversely, dementia for depression. Manifestations of depression, especially in older adults, include sadness, difficulty thinking and concentrating, fatigue, apathy, feelings of despair, and inactivity. When depression is severe, poor concentration and attention may result, causing memory and functional impairment. When dementia and depression occur together, as happens in many patients with dementia, the intellectual deterioration can be extreme. Depression, alone or in combination with dementia, is treatable. The challenge is to make an accurate and early assessment and diagnosis. Table 59-1. Delirium affects as many as 50% of people older than 65 years who are hospitalized, and as many as 80% of patients in an ICU. The impairment of cerebral oxidative metabolism is when the brain gets less oxygen and has problems using it. Pro-inflammatory cytokines, including interleukin 1, 2, and 6, tumor necrosis factor alpha, or TNF, and interferon, appear to play a role. Dementia is the leading risk factor for delirium. Furthermore, delirium is a risk factor for the subsequent development of dementia. Delirium may cause permanent neuronal damage and lead to dementia. Stress, surgery, and sleep deprivation have been linked to the onset of delirium. Pain and depression also contribute to delirium, especially in post-operative older patients. The pathomechanism of delirium is actually poorly understood. Clinical delirium is rarely caused by a single factor. Delirium can occur following a relatively minor insult in a vulnerable patient. For example, a patient with underlying health problems such as heart failure, cancer, cognitive impairment, or sensory limitations may develop delirium in response to a relatively minor change, such as using a sleep medication. In other non vulnerable patients, it may take a combination of factors such as anesthesia, major surgery, mechanical ventilation, infection, prolonged sleep deprivation to precipitate delirium. Delirium can also be a symptom of serious medical illness such as bacterial meningitis. Delirium typically affects older adults, 65 years and older, and more common in men. Other precipitating factors are history of dementia or related cognitive impairment, depression, and history of delirium. Some more precipitating factors may be related to the restraints, pain that may be untreated or the patient may not be able to express pain, and long periods without sleep. Precipitating factors continued can be related to immobility. This goes hand in hand with restraints and history of falls. Patients with delirium are typically sensitive to sensory overload. Generally, vision and auditory senses are affected. Medications may also cause delirium. Multiple drugs, opioids and or narcotics, alcohol, and drug abuse. Multiple medical problems can contribute to an array of conditions. Delirium is another one. Liver and kidney disease can lead to electrolyte imbalances, other neurological diseases, and infections may coexist or cause delirium. Delirium can be a result of surgery. The physiological stress of the surgery and sedatives alike may contribute to delirium. So you can see this is a mnemonic for delirium. It may help you identify some common causes, but the most common causes of delirium are dehydration, electrolyte imbalances, immobility, and infections. Delirium etiology is more of identifying the underlying causes. Many of these factors are treatable, such as dehydration, electrolyte imbalance, pain, and infections. Delirium in older patients may have limited compensatory reserves to handle the pathophysiological aspects of delirium. So, symptoms such as hypoxia, low blood glucose, or dehydration may occur. Many medications, including sedative hypnotics, opioids, especially Demerol, benzodiazepine, and drugs with anticholinergic properties, can cause or contribute to delirium, especially in older or vulnerable patients. Patients with delirium can present with a variety of manifestations ranging from hypoactivity and lethargy to hyperactivity, including agitation and hallucinations. Patients can also have mixed delirium, manifesting both hypo and hyperactive symptoms. Early symptoms include insomnia, loss of appetite, restlessness, or confusion. Late signs of delirium are misinterpretation of situations, misperception, and hallucinations. Delirium can last from 1 to 7 days depending on the severity of the underlying cause. Some patients do not recover. Manifestations of delirium are sometimes confused with those of dementia. A key distinction between delirium and dementia is that the person who exhibits sudden cognitive impairment, disorientation, or clouded sensorium is more likely to have delirium rather than dementia. A comparison of dementia, delirium, and depression is presented on Table 59 1. Diagnosing delirium is complicated because many critically ill patients cannot communicate their needs. The Confusion Assessment Method, or CAM, tool has been extensively studied and is a reliable method of assessing for delirium. Table 59 18 presents CAM. Diagnostic studies include blood work such as electrolytes to rule out acidosis, elevated ammonia levels, BUN, and creatinine. Drug and alcohol levels may be obtained. If unexplained fever or nuchal rigidity is present and meningitis or encephalitis is suspected, a lumbar puncture may be performed. Prevention of delirium involves recognition of high risk patients. Patient groups at risk include those with neurological disorders such as dementia, stroke, CNS infection, Parkinson's disease, sensory impairment, and older age. Other risk factors include surgery, hospitalization in an ICU, and untreated pain. See Table 59 16. Care of the patient with delirium focuses on eliminating precipitating factors. If it is drug induced, medications are discontinued. Keep in mind that delirium can also accompany drug and alcohol withdrawal. Depending on patient history, drug screening may be performed. Fluid and electrolyte imbalances and nutritional deficiencies, such as thiamine, are corrected if appropriate. If the problem is related to environmental conditions, such as overstimulating or understimulating environment, changes should be made. If the delirium is secondary to chronic illness, such as chronic kidney disease or heart failure, treatment focuses on these conditions. A therapeutic environment may include encouraging family members to stay at the bedside, providing familiar objects and family photos, transferring the patient to a private room or one closer to the nurse's station, and planning for consistent nursing staff if possible. Use reorientation and behavioral interventions in patients with delirium. Personal contact through touch and verbal communication can be an important reorienting strategy. If the patient uses eyeglasses or a hearing aid, these should be made readily available because sensory deprivation can precipitate delirium. Avoid the use of restraints. The interprofessional care team may need to address issues related to polypharmacy, pain, nutritional status, and potential for incontinence. Give attention to increasing physical activity or providing range of motion exercises when appropriate and maintaining skin integrity. Patient education materials are available at www.icudelirium.org. Drug therapy is used cautiously because many of the drugs used to manage agitation have psychoactive properties. Presidex, an adrenergic receptor or alpha adrenergic receptor, has been used in ICU settings for sedation. Haldol can be administered IV, IM, or orally and will produce sedation. In addition to sedation, other side effects with antipsychotics include hypotension, extrapyramidal side effects including tardive dyskinesia, involuntary muscle movements of the face, trunk, and arms, and athetosis, involuntary writhing movements of the limbs, muscle tone changes, and anticholinergic effects. Carefully monitor older patients receiving antipsychotic agents. Short acting by benzodiazepine or Ativan can be used to treat delirium associated with sedative and alcohol withdrawal or in conjunction with antipsychotics to reduce extrapyramidal side effects. However, these drugs may worsen delirium caused by other factors and must be used cautiously. It can be difficult to care for confused and combative patients, especially when it happens unexpectedly. What are some things you can do to deal with such behavior in clinical environments such as a hospital? Think of Joan in the sim lab. This concludes the lecture on Chapter 59, Delirium.